So Dr. Love KOCHGAWAY was for 10-15 years in Shankar Nethralaya as a pediatric consultant, and now he has his own center, Netralayam, in Kolkata. He's a pediatric ophthalmologist of national repute with presentations internationally and nationally. And he will be talking to us on inadvertent posterior capsule tear, no worries. This is one of our biggest fears, and he will tell us how not to worry. Dr. Love KOCHGAWAY, please.
Thank you, Dr. Satyajit. And one good thing about you is that you give the topic and we are left to find how to make it. And this is the only new presentation I made in this conference, and it was a good learning experience. So just before I start, let's go through the anatomy of the capsules. As we all know, anterior capsule is thinner, but while I was making it, I didn't realize that posterior capsule is so thin compared to anterior capsule. Anterior capsule being 14 microns, posterior capsule is 2 to 4 microns, and at equator it is slightly thicker. So PC tears, it can be of different types. It can be a pre-existing. In pediatric cataracts, we frequently encounter it as posterior lenticonus and a traumatic cataract. And in adult, it is most commonly posterior polar cataract. Spontaneously during hydro procedures, many times if you have a small rhexis and then the fluid gets blocked in the bag, then and there is an inherent weakness of the zonules, it just gives way during hydro procedures. And intrasurgical, it can be due to during nucleus management, cortical aspiration, or IOL insertion. Risks, all of us know about this. Just for completion's sake, corneal edema due to the more manipulation during surgery, hyphema, cystoid macular edema, and AC reaction, retinal detachment, decentered IOL. These are the risks when we encounter posterior capsular tear. So identification is very important, and this is a good video, what you can see here, and the mistakes that was done here. First mistake, it is quite obvious. It is a hard hypermature cataract, but the rhexis is quite small. So while manipulating, you can see the first chop has been made, second chop, and when you are moving it with a small rhexis, you are creating pressure on the zonules and posterior capsule. And when the third time it was being done, and this is the time probably when it gave way, because after this, what you see here is the nucleus has started behaving abnormally. It is going more towards the medial side. It's a temporal incision, and it would not rotate. So I had a understanding that something has gone wrong, but still trying to salvage the situation. As you can see, it's not rotating now after this. It's just going inferiorly. Then I try to center it again, and this time what I should have done earlier before initiating the chop, I tried then enlarging the rhexis margin, but probably it was too late by then. And then again, next sign what you see is the posterior dip of the nucleus. So it is quite obvious that such a whole nucleus with a PC defect or zonular dialysis, it cannot be salvaged, but you have to keep trying till it goes. And it's gone now. So at this point, you call your VR surgeon. Next is during cortical aspiration, better visibility of the tear directly, and this was again a very hypermature cataract, and AC, because of manipulation during surgery, there is sudden shallowing of the AC due to the iris coming into the port. And at this point, what you see is the PC rent has occurred. Yeah, it's quite clearly visible there. So this is another situation in which you can have a PC rent during cortical aspiration, and you have to be very careful regarding that. Again, you see this portion giving way. This portion, there is a PC rent and vitreous loss in the AC, so you have to do a vitrectomy in such cases. Next is probably the highest incidence is during the last nucleus fragment removal, and here, as it is a routine cataract, and this is one of the moments when you lose your concentration, and what you see here is while doing the, and here you see the rent is happened due to the phaco tip, and the mistake, again the mistake is sudden removal of the phaco tip. It should not have been removed suddenly. First the viscoelastic should have been pushed, and then the phaco tip should have been removed. So goals of PCR management: avoid, first most important, what all of us want is, we don't want to call the VR surgeon. So avoid nucleus drop, avoid damage to the corneal endothelium, prevent tear enlargement, preserve the anterior capsular axis, because we want to place the IOL in the sulcus. We don't want a scleral fixated or AC IOL. Remove the remaining cortex, especially those under the anterior capsular axis margin, which are the last to be removed. Maintain the wound size. We don't want to increase the wound size, and a well-centered IOL. If we are able to achieve this, then probably the damage is not done. So management strategies: first, analyze the extent of PCR. As you could see here, it is this portion. Status of the anterior hyaloid face, whether the vitreous loss is there or not, location of the nucleus, comfort with anterior vitrectomy, and availability of VR surgeon. Luckily, we have quite a few VR surgeons with us, so that stress is not there. So early response, as you could see in this case, the case I had shown, the PC rent here, that we are continuing. After that, the AC is formed with viscoelastic, and if vitreous loss is not there, if there is no vitreous in the AC, the remaining portion of the nucleus can be very easily emulsified, and ideally the PC posterior capsular tear should be plugged with chondroitin sulfate, the dispersive viscoelastic. Then the chances of further vitreous loss will not be there, and nucleus can be emulsified. So in this case, what you see is, in one hand I have a visco cannula by which I am pushing the viscoelastic and simultaneously emulsifying the remaining portion of the nucleus. And this is especially in the last stages, when you have the final fragment, or during after the cortical, during cortical aspiration if you are having. Vitrectomy tips, again, pars plana or limbal. Honestly speaking, pars plana would be a better procedure if you have a PC rent, because when you are doing it posteriorly, you are pulling the vitreous inside, and then the enlargement of the PC rent, chances of that is minimal. But since most of us are not trained to do it, and we are not comfortable with that, then we do the limbal route. And ideally the cut rate should be high, cut rate and high vacuum, and go deep into the vitreous cavity, so that vitreous loss in the further vitreous loss in the anterior chamber is avoided. End point, when the posterior capsule falls back and there is no vitreous in the anterior chamber. And always, as Dr. Srinivas had shown, we can use triamcinolone assisted vitrectomy as well, to see whether vitreous is there in the anterior chamber or not. Phaco versus ECC, again, whatever works best in your hands, that should be selected, but these are some of the tips which we have already discussed. IOL scaffold is another thing what we can try in this last piece. Better if we implant the IOL in the sulcus, keep the nucleus above that, and then the remaining piece can be emulsified. IOL placement tips, again, if it has to be placed in the sulcus, sometimes with a small rent we can always put a single piece IOL in the bag, but if it has to be placed in the sulcus, it has to be a 3-piece IOL, and clear the vitreous from the anterior chamber, and you should be absolutely sure about that before doing the IOL implantation. And once it has been done, then I generally use pilocarpine to see whether the pupil is round or not. And a round air bubble also helps us to identify that there is no vitreous in the anterior chamber. Thank you so much.
Thank you for that beautiful presentation, Dr. Love. Once you have completed the surgery, you have had a beautiful centrally placed lens even after posterior capsule tear. Do you actually tell the patient that something like this happened?
Yes, yes, I tell. I generally tell, and no need to magnify it, but patient should be aware that the PC rent has happened, and general my language is that the support of the lens was weak, so we have placed a different, and many times you have to change the lens.
Yes.
So if you are changing the lens, you have to also inform the patient regarding that.
Dr. Arun?
Excellent videos. Just I'll like to add one more thing. Once you are phacoemulsifying the last piece of the lens and you had a PC rent, what you can do is you can use an IOL as a scaffold, and then you can do the phacoemulsification of the last few pieces. That will prevent further loss of nucleus fragments into the vitreous. Just one more.
Yeah.
Sometimes while injecting the lens, even the single piece lens, suddenly it can eject out of the cartridge and hit the posterior capsule and cause a rent. In that situation, I've seen some of the surgeons placing it in the sulcus and doing the optic capture. It may work, but it's always better to do the reverse capture of the anterior optic, keeping the haptic in the bag and taking out the optic and then reverse capturing the anterior capsule. That is so without sacrificing the lens, one can use that.
Yeah.
Anybody has a question, please?
Yes.
First, if pre-operatively you have to identify cases. See, especially if it is a posterior polar cataract, traumatic cataract, posterior lenticonus, if we have identified it pre-operatively, then definitely we'll be more careful and chances of success is much higher. So identification is important, I would say. I don't think so, sir. No, no.
Dr. Subhash is suggesting you do some puja also pre-operatively.
The pre-operatively, what our regime in the OT is, we always keep our vitrectomies ready before we start any surgery. So this is one of the pre-operative things. Everybody should have their vitrectomy ready before the surgery, so that you don't waste time preparing a vitrectomy, the assistant connecting the vitrectomy, running a test, and then handing it over to you. So always keep your vitrectomies ready before.
Which brings me to the question, Dr. Love, for the benefit of the audience, what are some of the things you would suggest that you must have in a cataract surgery which you do not routinely need, but you must have it in your OT?
We have an emergency tray in our OT that has vitrectomy, that has CTR, that has capsular hooks. Because most importantly, CTR, many times when you want a CTR, it will not be there. And even after having that tray, many times we don't have it in that tray. So these are some things which should always be available in our OT.
So things like pupil expander, triamcinolone.
Yes.
Those things. Thank you very much. Sorry, please, ma'am.
Yeah, in those cases, especially in hypermetropic cataracts with hard cataract, hypermetropic hard cataract, mannitol will definitely help. Three-piece lens, sulcus lenses are mainly three-piece lenses. Though some doctors do advocate single piece, but there is no evidence for that. And reason being, single piece lens are thick, and if it is thick, then it will keep on with pupil reaction. It will keep on rubbing against the iris and cause pigment dispersion.
Hydrophobic lenses are strict no in sulcus because they are going to rub against the iris and they can cause chaffing. So if you don't have a three-piece lens in your OT, either you can defer the implantation to some other point, or hydrophilics can still be tolerated in the PC, but it is not advisable.
Yes, PMMA is again a three-piece.
PMMA, yeah, that's again best. PMMAs are good.